I'll give it a crack.
Yeah.
I'll tend to focus on breast and body, obviously.
Yeah, no problems. Redirecting to Facebook Live page, getting there.
Wow.
So hopefully we are on. Yeehaw, we're on.
Fantastic.
Awesome. So hopefully we've got a few people coming on now. So I want to invite everyone to come on. I know, yay, I can see you're on there, you beauty. Oh, hang on, it's gone somewhere else. What's happened?
I saw something disappear.
Yeah, me too. Hang on, let me just jump on the group and see if it actually worked out. This is the first time we're doing all this, Lee, so just be patient with us. I thought I'd be really technical and go on first and put a post in, because to get us both on the live, we have to do it through Zoom. And so to get it in the event, oh, it looks like it's not on there. So hang on, let me have a look. No, but it looks like no. So that's on there. That's on there. Okay, so that's in the group. I'm just gonna hang on. I have to try this again. Just give me a second. So somehow we got booted out, didn't we? I think. I don't know.
It says live on Facebook. Hang on.
Are you serious?
I've got live on Facebook on mine.
Okay, let me just have a look. What's
using enhanced encryption, meeting information.
So funny, so techie, and not so. It does say live on Facebook.
It
so
does.
Why can't I see us in the group? If anybody can see us in the group, can you let me know or message me or something if you've got? I'm going to have a look on my phone and see, because for some reason it's disappeared for me in the group. So I will see if we are live in the group. Oh my God, we're live in the group. How embarrassing. We've been on for 1 minute. So welcome everyone. Welcome everyone. And welcome to Dr. Kumar. I feel so ditzy after all of that. But anyway, I just want to introduce you to Dr. Rohit Kumar. Now, he's one of my favorite plastic surgeons. Honestly, I do have a few of them, but he's one of my very, very favorite plastic surgeons. And he's been a great supporter of Plastic Surgery Hub and helping patients, answering questions. When I've got questions from people that I can't answer, I can just reach out to him and he'll just answer anything. So he's got, and the fact that he's here tonight when he could be with his family. So we really, really appreciate it. But I'm going to pass it over to him. And while I'm looking up the questions, because we've got a bunch of questions that he's going to answer, I want to let you know, so his clinic is in Sydney. It's at Leichhardt. And I've been to the old one, I've been to the new one. So it's a beautiful clinic, can't recommend it enough. And he's actually got one of the best injectors in Sydney that works with him as well. So if you're looking for injectables,
this is true.
I know. Sorry, I thought I'd just get that in there because I know that she's amazing.
Thank you.
Yeah, she's amazing. But yeah, I'm going to pass it over to him. So he's in Leichhardt and he specialises in breast and body work. So I know we've got a couple of questions that might not be related, but he's going to give them a crack as well. So yeah, so welcome. Thank you for joining us.
Thank you, Trish. No, I appreciate it. Hi, everybody. I can't sort of see any responses yet, so I'll just sort of wave and assume that there's people there and say hello to you. As Trish said, yeah, look, my main rooms are in Leichhardt, but if you're Penrith-based, I'm also in Penrith, and I also go as far as Orange in New South Wales. So the western corridor of Sydney, I guess, including the inner west, is where I'm based. So yeah, that's and we've got the new rooms now on Norton Street as well. So yeah.
Awesome. Now with Zoom, we've got a little bit of a lag, so there might be, late questions coming in,
That's fine.
As well. But I'll just keep transferring over. For some reason, here we go. Now I can actually see them as we go. Okay. Beauty. Awesome. So welcome, Danielle. Welcome, Carla. So I'm really excited to have everyone here. So the first question is there a surgery to get rid of excess skin around the knees? And if so, is that even possible?
We get asked this question a lot, actually. It's interesting. The long and the short of it is yes and no. If the skin is actually falling down and draping around the knee, then you might actually benefit from a thigh lift in total. So that's a cut on the inner thigh that lifts the inner skin up, and a cut on the outer thigh or on the hip area, which will pull the outer thigh up, sort of like when you put a stocking on. That can get rid of a lot of the overhanging skin if it's sort of the whole skin is loose from the top down. If it is located just around the knee, which it does happen in some patients, that's a lot harder. I think, it depends on whether you wish to have scars and where you are comfortable showing scars, because often the worry is that you've got the skin around the knee, you want to wear shorts and you're worried about that. So you've got to then sacrifice or compromise skin for scar and work out whether that's possible or not. So yes, you can excise skin from around the knee. It's not a very common procedure. It's usually a continuation of a thigh lift, and we go down up to around the knee and pull all the skin up. That's usually the way to get that. A targeted knee exposure area, a lot more difficult, and it really depends on the individual circumstance.
So with that thigh, because only because it's giving me a question. So when you say the thigh lift, so when you say the outer thigh, like where's the scar? Like, is that on the line of the undies, or like does it go that way around your leg?
That's a good question. So when you think about a thigh lift, when I talk to my patients about a thigh lift, or when I talk to my patients about an arm lift, right? Similar concept. Think of it as a barrel, right? So think of it as a circular structure, and it's a barrel. Now you're going to have an inner barrel, and often my patients will see me wearing jeans in my consults, and that's for a specific reason. The jeans I buy have a yellow seam line, and it actually shows if you wear jeans and you see where that seam line is on the inner aspect of your jean, on the inner thigh, that's pretty much where you would do your scar for your inner thigh lift. Now that will go all the way up, and in some patients, it will go in the panty line in the groin crease itself. So in the crease and down. So like a sort of very lazy Y or like a T.
Yeah,
and that's the same. Yeah, and that's the same in your arm, where you would go in your armpit and all the way down here. So it's the same concept on a barrel. That's the inner thigh. Now, there will be patients who need both those cuts, and there will be patients who need just the cut in the panty line. So just that lazy one, and not need a cut all the way down. Now that will depend on a lot of factors: your quality of skin, how much extra skin you have, what you want to achieve, where we can remove the skin from. So those are a few things that your surgeon will have a look at and tell you. But not everybody necessarily needs the full cut. Some people can get away with a much shorter version. Now that's the inner thigh. You can't do the same on the barrel. So, if I put these two fingers together, where those fingers meet is one seam line, and where the fingers meet is the other seam line. So in the inner thigh, you can do that cut where the fingers meet, and that's your seam. But you can't do that on the outside, because that will leave you with a very long cut all the way on the outside of your thigh, and we can't really pull tight in that area. So what we actually do is, normally it's a continuation of your tummy tuck, because usually that's where you've got a lot of skin. It's weight loss patients that have that. Normally you go on the hip line or belt line, and you go out across, sort of slightly below your love handles, and you go across that. And then often that is combined with a buttock lift. So it's like pulling suspenders, or pulling stockings up. So you're pulling the bottom up, and you're pulling the side tissue up to pull up the outer thigh. So the outer thigh doesn't get a actual long cut. You do that, you pull the outer thigh up, get it as high as you can, and then any loose tissue, you pull the inner thigh, and that one you can do with the cut.
Right. And so, because you're lifting it all, like, what kind of holds that all up? Is it just the skin that holds it all up? Or?
Once we figure out a way to hold it all up and keep it up there for a long time, whoever does that, genius. There's so many techniques on trying to suspend the tissue. Often when we're talking about a thigh lift, the patients that are looking for that, they know that the quality of skin is not very good. The skin's going to be thin, the skin's going to be sagging, which is why you're having the procedure in the first place. So when you hoik it all up and you tighten it all up, the skin inherently will want to drop back down again, right? So I speak to my patients when we talk about it. When you've gone out and gone shopping, and you've got a plastic bag, the old Coles bags, and if you fill it all up, that's great. You come home, you empty it, you still just got a Coles bag. But if you overfill it, some of the bag stretches, some of the bag thins out. Now, when you come home and you empty everything, those thin pieces of plastic don't go back to being that bag again. And that's what we are working with. So when we cut and when we stitch something in a thigh lift, for example, or a buttock lift, or even a body lift in that situation, we're dealing with very poor tissue. So they won't naturally try and stay up there, although we will try our hardest to try and get them to be fixated. There are not a lot of structures in that area that you can hang off, suspend off. You have some of your body's natural fascia layers, things like the scarpus fascia in your tummy. But when it comes to the inner thigh, a bit on the outer thigh, but the inner thigh buttock region, but the only thing that you can suspend it on is the fascia or the periosteum that hangs around the bone of your hip bone. Now, we don't always do that. Some doctors will really try and reef it up there and really hitch it up so it stays on that bone. That's the solid structure. But you're going to sit on that. You're going to move. It can be quite painful, and it can be quite annoying for a period of time. So we work it out on depending on what and how much we excise, how much suspension we need. So if we need to suspend, we'll suspend on the periosteum around the bone, or we'll suspend on the fascia that you have, hoping that you've got a reasonable amount of strength in that layer. But other than that, there isn't much, which is why when you do these operations, you always tell your patients that there is going to be some sagging, some stretching, and some potential revision in the future.
Yeah. Okay. And I guess it's a little bit like if you don't put on, like if you keep the weight off that you've lost, you've probably got less chance of sagging, I would think. Whereas if you're
absolutely, I mean, look, it all helps, right? It all helps. I think the crucial rule in this procedure is always when to do it, and how to how to maintain it. And one of the crucial things on when to do it is that you would only, and I ask my patients to come back when they're ready. You only do this operation when your patient has achieved their goal weight or close to it. Because of course, when you remove the tissue, you're going to get a little bit of a couple of kilos closer to their goal weight anyway. But also, just as important as that is you need to be able to keep that weight off and keep it stable. So if you've got yourself to a comfortable goal weight that you are, we won't operate on you till you've maintained that weight for a minimum of 3 months, ideally 6 months.
Yeah.
That tells us that the lifestyle that you are now into is going to be reasonably stable going forwards. You haven't gone on a crash diet. You haven't just, tried really hard to get to this weight and then come for surgery. Because once you do that, you won't be able to maintain it after surgery. You'll stretch, you'll gain weight, and it'll all start sagging again. So stability and a goal weight and maintenance of that weight for a minimum of 3, ideally 6 months before you consider your surgery.
Yeah. Yeah. No, that makes so much sense. And, it's true. Even like I've heard people that have, stay stable for, even a whole lot longer, just so that they know in themselves that with the money that they're going to be spending, it's well spent because they know they're going to be like that,
Absolutely.
Forever.
So the numbers I'm giving you are the absolute minimums. You choose to do the operation when you are comfortable in yourself and you are stable in yourself. And if that takes a year before you get to that, so be it. There's no, the longer the better. The longer you can maintain it, the better. So there's absolutely no need to force you to do it just because you've got to 3 months of stability.
That's true. There's not a race, hey?
No, not at all. If it's taken, I tell my patients, if it's taken a year to lose the weight, expect a year of operating to get you to where you want to be. It's not going to just happen with one operation.
Yep, that's true. So true. I like the longer time. It just makes me feel safer. All right. Well, Kim has asked a question now. She's actually, I think she's seeing you very shortly. She'll be seeing you on the. Yeah. So what are the different therapies that you recommend for scar treatment? I have a few more, but I see him on the 11th of February.
Oh, well, so, well, I'll answer this question. That'll make my consult with you 5 minutes less.
Shorter.
Look, scars can be easy and scars can be hard. I think that's the simplest way to start that conversation. When I speak to my patients about body contouring or body scars, I always tell my patients, look, you need to be comfortable to substitute skin for scar. There is no plastic surgeon that can do an operation and leave you scarless. Every operation will leave you with a scar, okay? Our job is to try and place these scars in positions where they're less visible, hidden in body creases, or orientated in a way that is far less likely to be noticed by other people. But you're going to get a scar, okay? That's just no ifs or buts about it. You're going to get a scar. My common thing with my patients is I tell them, if the scars look really good or the scars go well, you can thank me. If the scars go badly, blame your parents.
Yeah.
Genetics plays such a big part in how we scar, what we do, tension of the operating, etc. But genetics and how you scar is how you will scar. So when we come to deciding on how we're going to treat the scar, should you develop it, it will boil down to a lot of factors: where the scar is, how long it is, how long it's been there for, how it's behaving. Some scars widen, some scars heap up, some scars combine the both. Then you start looking at your hypertrophic scars and your keloid scars. So there's a gamut of different types of scars that we have to look at. And you can start with very, very simple things, such as moisturizing the area and massaging it and doing it regularly, 3 or 4 times a day. My patients often ask, how often should I be doing my massaging of my scar? And my simple answer is, if you're thinking about it, you should be doing it.
Yeah.
Right. So 5 minutes 3 times a day is the minimum, but you can do a lot more than that if you want to. So moisturizing and massaging is one very good, very well proven modality to help soften and improve the scar. Pressure can also help. So sometimes we'll put silicone strips or silicone tape. Silicone as general can help. So we look at those techniques as well. Then there's the sort of other non-invasive techniques like LED light therapy, which has actually been shown to improve scarring, as well as things like skin needling, which can improve the scar. Pressure suits, or the garment suits that we have, can also improve it. And then also, if we have to, and if there's a problem with the scar, we can inject corticosteroids into the scar to soften it down. We can use lasers. And in worst case scenarios, sometimes we bite the bullet, cut it out, and start again.
Yep.
So
it's really interesting. And I think it's true about, because I'm a really bad scarrer, and my son had 2 surgeries within 6 months, one on his wrist, which is from a broken bone, and that's got a really bad, heavy keloid scar, and he's got one where 6 months later he broke his collarbone, so he's got one all the way across here, and that was only 2 months ago, and that's healed beautifully. So even the same person can have a different healing in a different part of the body.
Exactly. I mean, we know that some people have a predisposition to forming keloids, right? We know that some people have bad scarring, but while that gives you an indication, it's not a predictor. I've seen patients who have bad scars in one place, but you operate in the other area and they don't. Yeah, exactly as you said, you wouldn't be able to tell. Sometimes it's location specific. Sometimes it's the amount of tension that's in there. And sometimes it's just what your body decides to do.
That's true. And do you, just on this point, because I'm a real advocate for Strataderm, do you ever suggest anything like Strataderm?
All my patients get a Strataderm pack as part of their post-operative package, actually.
Awesome.
Look, I'm a strong proponent of silicone. Now, Strataderm I like because it does work very well, but it's not the only one out there. There are other silicone-based creams and tapes. But yes, I find that, we still don't know, even after all these years, it's interesting, we still don't know exactly why silicone works. And there's a small subpopulation, 1 in 10 people, that get a bit of a red reaction when we use the tapes, etc. But we find silicone. Are you one of them, are you?
I welt up like crazy.
So there's a small group of people that happens to, but in the ones that it doesn't, and in the ones that work, and there's a good population of that and good studies, it works really well. We just don't know exactly what that will be, or who that's going to be on.
Yeah, that's so good to hear. Now, Kim has just said that's her Lifetime Achievement Award, so she must be someone who tries to spends her life trying to get rid of scars.
Well, we'll do our best. We'll certainly do our best.
Awesome. Now, okay. So this came through on the group. I believe that a great boob surgeon does not necessarily make a great facelift surgeon. Do you do faces? I like that question.
That's a good question. So that implies that either I'm a great boob surgeon.
That's really funny.
Which I like.
Got that. Yeah.
I actually agree with that sentiment. Look, I think that the days of where a general plastic surgeon, and yes, there are quite a lot of my colleagues who are general plastic surgeons who do everything. Um,
Mhm.
but I think that, it's the old story. If you do something and you do something a lot of times, you get very good at it. And there has been a general trend now, even your GP, your GPs are starting to become more focused on women's health, or more focused on
Yeah.
sports physicians, or even cosmetic GPs, right? You've got that group. If you go to see your physicians or your general surgeons, they're not just a general surgeon anymore. They're a general surgeon who's a hepatobiliary surgeon, or a breast and endocrine surgeon. And I'm seeing that happen more and more in plastic surgery, where you've got a plastic surgeon, but they're focusing their energies in what they like the most, and they concentrate purely on that. And I think you get your best results in that situation. Me, for example, breast and body, post weight loss, mommy makeovers, breast, tummies, thighs, arms, right? That's what I do every single day, day in, day out. So of course, your technique, your stitching, your timing, your team that works with you, all of those things get gelled together and work very, very well. I think if you're doing something like a facelift, it's a very complicated plastic surgical procedure. There are things that can go wrong that you can't hide. If you've got a scar on your breast or a scar on your tummy, you'll be able to wear an underwear or a bra and you'll be able to get away with it. With your face, you hit the facial nerve or you get a bad scar, that's a much harder thing to hide. And the same applies to noses, right? So you've got to be someone that does that day in, day out, and very, very familiar with it. That's why I don't do them, because I wasn't doing enough of them. So when someone does come to me to ask to do those specific components, so say a nose or a facelift, I'll pass the patient on and refer them to a colleague that I trust, that I would send my family to look at those components. And I focus on what I know I'm good at and that I do a lot of, and therefore I know I can get a great result of.
Yep, I agree with you 100,000,000% with that one, because I think you want to get the best job for what you're going to have done. So you might have done a fantastic mummy makeover surgery, but if I'm going to have a facelift, I'm probably not going to come to you.
No,
Well, you won't do it anyway.
I would do it. So when patients do come to me, I've got patients that make inquiries, or patients actually, because there's, when you lose your weight, sometimes you've got a bit of extra weight here too. And patients will say, now, you've done everything else. It looks fantastic. Can you do my neck, or can you do my face? And if it's not at a level where some fillers and Botox, Dysport, anti-wrinkle injections would work, then I just say to them, look, that's not something I do. I'm going to pass you on to a colleague who will finish this last bit off for you if that's what you want to do. It's just an area that it's something that I just don't want to stuff up for the patient. They put a lot of effort, time to get there. It's expensive. So you want to do it once and you want to do it right.
That's so true. Now, on that, Kyla has actually asked, she just said, Rohit said no when I asked for a facelift. I have a question around weight gain. After a tummy tuck and lipo and you gain weight, can you get a fatty tummy again?
Yes.
I can answer this.
Simple answer,
to me.
yes. You get fat removal is permanent, right? You're born, the one of the good things, if you like to look at it, is you're born with the same number of neurons, and once they die off, you don't recreate your neurons. So we all basically get dumber as the years go on, because we keep losing neurons. And it's the same with fat cells. Unfortunately, it doesn't quite work the same way for most of us. But once you take away your fat cells, they're gone. But that doesn't mean what's left there can't behave in an excessive manner, because fat cells tend to stay in two states. So just in a very sort of simple way, you have fat cells that are actively moving, actively awake, if you like. So they're the ones that are gaining and losing when you're eating and drinking. Then you've got fat cells that are asleep. So they're really not part of the equation. But if you take the other fat cells out and you eat just as much or continue to eat, then those fat cells that were asleep, they'll wake up. And once they wake up, you're going to get large again, or larger. You can often see it in those movie stars who go on a crash diet and they've got like really thin bodies, but they've got like I call them a lollipop body, where they've got a big head and a thin stick frame. They've taken fat out of everywhere, liposucked everything else, but there's other fat in other areas, and they'll start to expand as well. So you get a combo. So No, you don't. I think it's a very big mistake to think that I'll have my tummy tuck, I've got my lipo, I can go out and have 4 burgers now, because you know what? You will end up paying for it at some stage.
Exactly. And just to help from a personal situation, when I put on weight, even though the lower part of my stomach stays bigger, I get this extra sausage that kind of grows under my boobs, above my belly button. That's kind of where the fat comes, and around the back. So because I put on COVID weight, which I'm losing now.
We've all got our COVID kilos. Don't worry about that.
Oh, it's stressful.
We've all been there. I'm suffering from that in a really, really, really bad way.
Oh yeah, but anyway.
But no, hiding for a year. The other thing is, of course, when you've had surgery, it's a cut from skin all the way down to the muscles, for example, right? Mm-hmm. It's a shelf, it's a ledge. You can build above it, and that shelf will hold it, and then that's where you fold over and start to get your sausage type shape. So that might hold it up there like a dam. It's often, ladies who've had cesarean sections will be familiar with this, where they've had the C-section scar, and then they've got a shelf or a paunch just hanging over the top of it. And that's exactly what you described.
Yeah, I had the paunch without the cesarean. There you go. All right, next question. So, Margaret asked.
So, just 1 second, Trish. Just give.
I wonder if he's saying to the kids, can you be quiet, or something like that, or the dog's come in and he's got a new puppy, and the dog could have come in and done something. Who knows?
Sorry, Trish, you are quite right. I had the dog running up here, and I quickly had to get him out of here. I'm sorry. I'll show you a puppy in a second.
I was going to say, you need to show him before you go. He's the cutest dog you've ever seen.
But he's not supposed to come up in the study, so it was just like, get him out of here before he goes crazy and there's too much stuff around.
I love it. All right, so the next question is from Margaret. Margaret wants to know about surgery to remove excess skin from calves. Now Margaret's lost over 100 kilos, so I get that. So where would the scar be, and recovery time?
Margaret, that's an incredibly, incredibly difficult question to answer. Calf reduction, removal of skin from calves, is not a very common operation at all. It really depends on where the skin is, where the excess tissue is, and how to whether we can actually physically, that there's structures and muscles underneath the calf and the skin itself and nerves that actually make removing skin from calves very difficult. I know there are some doctors in Korea, South Korea particularly, that do liposuction and work around the ankles and reduce the calves. And yes, we can put calf implants in, but a physical reduction of calf tissue and skin in that area, it's not really something most of us would do. We would have to really assess it before we worked out whether it was even doable. That's a hard one.
Yeah, because I've heard as well that the lower legs are really hard to operate on, because I don't know why, but I just remember someone saying, I wouldn't, do that. It's just too difficult.
Yeah, very, very difficult.
All right, so I've got another one. Now, I'm after breast implants, but concerned about choosing the right size for my body type. Is there an easy way?
Yeah. You're throwing me the curly ones today.
I know. I'm so sorry I didn't send you any questions before.
No, this is again a very, very good question, because choosing a breast implant is a two-way street. Your surgeon should be able to look at you, measure you, work things out, and be able to give you a broad idea, or at least a group, to say these implants would suit you best for your frame, for your dimensions, for your shoulder width, for your waist, for your height, etc. Right? So your surgeon should give you their expertise and advice on which implants best suit. On the other hand, you also have to give in advice to say, well, this is the look I'm going for, whether I want a high upper pole, whether I want a full upper pole, I want a more natural look, whether I want large breasts, etc. So somewhere along the line, there has to be a marrying that both surgeon feels that they're comfortable that they can do that for you, and you feel that that result would be something you're happy with, right? So that's the first thing. Once you've got that, how you work out whether that is going to look right for your body or not, there are a few different ways that you can do that. The old school surgeons, the old guys would say, well, okay, we've worked out that about a 400cc implant is good for you. Well, here's a bag of 400 grams of rice, put it into your bra, etc., and try it on, put on a bra, and just have a look at what you're going to look like in a dress, etc. That's an old-fashioned technique. The newer techniques had breast silicone implants that actually sat reasonably well on your breast, and you put a bra on. But again, a lot of these techniques were what you would look like in a dress, what you would look like with some item of clothing on, not necessarily what the breasts themselves would look like. The more modern approach to this is something, for example, that I have in my practice is we have a Vectra machine. We have a Vectra 3D machine where the patient comes in, we do a 3D image. So we take a photograph, it's a proper three-dimensional image of the patient. And then what we do is we can say to the patient, here you are, this is what your breasts and your body are going to look like with the 300. This is what your breast and body is going to look like with the 400. Compare them both, show you all in a full 3D sort of rotation. So the practices that carry something like a Vectra would be the ones where you could go in, have a look, and see what it looks like. There are a few other 3D imaging things that are out there now. Chrysalix is another one that's there. So there are some practices that have photographic 3D imaging ones. They're probably the ones that will give you the closest, I guess, an idea. But you always have to remember that what gets projected on the computer, what gets projected, often the surgeon's result will be better than that.
Yeah,
but at least
it's like the try before you buy.
Yes, absolutely.
Almost.
And we offer that to all our patients as well. You know, come in, have a look. Don't even have to see me. If you're just curious, come in, have a look, see what you're going to look like, speak to my patient coordinator, try it out. And then if you think that's something you want to then progress, then come in and see me. So that's what the Vectra does.
And so with the Vectra, is it only boobs? Can you do other, like,
well, depending on who's got which particular type of machine and software, but you can do the face, you can do the breast, you can do the tummy. So, and you can do breast augmentation, breast reduction, breast lift and implants, rhinoplasty, so nose and face. And we can even show what someone might look like if they had a bit of 1 or 2 mils of filler. So
yeah, right.
It's quite a good tool.
Okay. Yeah, amazing. That's come a long way. Like that's
it's fantastic,
crazy.
and it's almost photorealistic. So when you're looking at it, remember, it's not like looking and you're thinking, oh, that's just a computer image of me. It actually kind of looks like you, very close to looking like you. So you know, including every single mole and every single spot and scar on your body. So it, you know, you really are looking as though someone is looking at you.
Yeah, totally. So, oh, hang on a second. Oh, here it is. What does gap surgery mean?
Gap surgery can mean different things in different situations. There are some procedures, and it's a bit of a technical one. So as everyone knows, there's public and private hospitals, right? There are some operations, skin cancer, for example, a broken arm, all those sort of things, that if you did break your arm, did have skin cancer, you can just go into a public hospital system and have that done. And there's no fee, no charge for that. If you wish to have it done by a surgeon of your choice, if you wish to go into a hospital of your choice, if you wish to go at a time of your choice, then if you've got private health fund, you can go into a private hospital and do those operations that way. Now, often what will happen is that there will be a cost of the private hospital. Often there will be a cost of the anesthetic. Often there'll be a cost of the surgeon. And then the hospital, then your health fund, will pay, or based on the bill that your surgeon, the hospital, anesthetic gives, your health fund will see how much of that they pay. Now, that health fund rebate has not changed since like the 70s. So when they pay the surgeon, they pay the anesthetic, they pay the hospital, there's usually a gap between what we charge now and what the health funds pay. Now that's called a gap. Now, depending on the procedure, depending on the surgeon, depending on exactly what we are talking about, some surgeons will say, well, for this particular operation, I'm not going to charge you a gap. So whatever your health fund gives me, I'm happy with that. So that's one thing. Sometimes people will say, look, we're going to charge you. So that's a no gap, right? Sometimes they'll say to the patient, listen, whatever your health fund gives me, plus $500 from you is what what we'll take. And that's
Yep.
what we call a known gap. And that's also something that some surgeons have negotiated with the health fund. So if you're a provider of known gap, you can do that. And then there's a scheme, a gap access scheme, where in very special circumstances, where the condition is life or limb threatening and you specifically apply for it, and you may have to still wait a year or 2 years before it actually you get there, operations that we would normally not provide in that situation may be covered for you.
Okay.
So at the end of the day, it boils down to what you have, and it also boils down to the discretion of the surgeon. Not all surgeons will offer a gap or a known gap or a no gap for all operations. They may apply it to specific procedures or to a specific circumstance, but it's a conversation with the surgeon, and it depends completely on the surgeon.
Got it. God, that's the best explanation I've ever heard, because it's so hard to understand and translate. Now, I've got a question on here, but I've got one here, so I want to make sure I get the right one for, oh yeah. Okay, so if an old scar line from a breast procedure is causing pain, is it possible to have a procedure done to fix or remove the scar tissue or whatever it is causing the pain? And would an MRI or something be helpful? The surgery was done over 5 years ago.
And that's a difficult, the pain in surgery, in any situation, whether it's breast surgery or any situation, is one of the most difficult things to handle, because pain is multifactorial, as we know, and there's a million and one things that could be causing that pain. It could be the scar, it could be the new tissue that grew there, it could still be some stitches that are still sitting there. It could just be the fact that you've had surgery and you've had the area operated on, right? So there could be a whole host of reasons why you're getting that scar. That pain in that scar. Step one would be to actually investigate it. And yes, an MRI might be an option, depending on what your surgeon thinks. If they run their finger in the specific areas which they're tender, there might be a lump. This is a thing that we might be thinking you might have what we call a neuroma. So there's excess nerves growing in one area, and that area is particularly tender. Well, then we might be able to see that. Then sure, we might investigate it further. And yes, sometimes removing that painful scar gives you relief, but there's no guarantee of that. Sometimes we actually inject Kinacort, which is a corticosteroid cream, into scars, thickened scars that are either painful, itchy, red, or swollen, and we can often get good relief from them. So it really depends. It's a difficult one without physically seeing the scar and seeing the nature of the scar to work out what is going to be required. But yes, sometimes excising the scar and starting fresh can fix the problem.
Yeah, right. Because it's really interesting that someone asked that question, because sometimes on my breast reduction scar, I get this really tight feeling and it's like really, really painful. And someone said to me, oh, that's nerve pain.
It might be, but you're going to remember the one thing that I tell everybody when it comes to scars or any part of our body, the body is super lazy. Okay. And what I mean by that is that if you injure your joint, if you injure your hand, if you injure your tendons, if you create a scar, make a cut, what the body wants to do is go back to a position of the least resistance, just collapse in, do the what would be the least amount of work or effort for it to do. So, you know, if you cut your finger here, the scar will want to do that, because then you just don't have to do anything. If you cut a scar, it just wants to contract in. If you operate on your joints and you just leave them in one position, they don't want to extend and contract. They'll stay there, and which is why you need physio, etc., to keep stretching it. Otherwise, that's what you're stuck with, right? And that's the same with scars. Over time, scars contract, and if they contract and pull other surrounding tissue down, then that can mean that things are left tight. That can mean that it could be pulling on nerves. It could mean that someone who's got a breast implant, for example, is developing a capsular contracture. So, scars just want to rest in their native, position, which is the least amount of work that they need to do, which means contracting down.
Yep. Okay. Yes. Yeah. My body's like that. My body's that lazy that it wants to just do nothing. Yeah. Okay. I
do that every day if I can.
I know, me too. I'm really mindful of your time, because I know we've been going for nearly 40 minutes now. So I'm going to actually just ask you one more question.
Far away.
I have to read it though, because it's far. I've just recently had a saline implant rupture. Would you remove the other one and and replace both, or just replace the ruptured one? I have no problems with the other one whatsoever.
We would remove both and replace it. Saline implants, I think you will find, if you did a survey of the majority of plastic surgeons in Australia, I think you'll be lucky to find a plastic surgeon that utilizes saline implants. They are often used by doctors calling themselves cosmetic surgeons because they're cheaper. They don't give you as good a result in terms of aesthetics as a silicone implant does. And they have this thing where they rupture and then you basically got an empty bag. So while the other side's good, and hopefully, look, there's nothing physically wrong with getting a saline implant. That the Americans were using it for a long time. But when there is something better out there and has been out there for a long time,
why would you go back?
Why would you go back to saline implants, which sort of came in when everyone was afraid of a whole bunch of breast conditions when they first came out? I think people are a little bit afraid with ALCL, etc. these days, but just if you just put a bag of water into your breasts, they're never going to shape the breast. They're going to slosh around. They're going to cause a very different appearance, in my opinion, anyway, to a teardrop shaped or even a properly done round implant. If you've got a rupture and one implant is gone, we will still ask you what you would like to do. If you are absolutely adamant that you want to just put in another saline implant and you're very happy with the other one and you don't want to touch, look, it'll be a conversation with your surgeon, and your surgeon should at least, respect your wishes. However, most surgeons would say to you and give the advice that 1, they're saline implants, 2, they're more likely to rupture, 3, the aesthetic appearance is far inferior to what we can do nowadays with silicone implants. And if you've already got a rupture, take it out, take the other one out, start fresh, let them age at the same time, let them all heal at the same time. You're resetting the bar for both of them as you're going on.
Yep. Awesome. Can I just ask, because she's just sent through another question on that one there. What type of implants do you use? Are there any that you would recommend over others?
Implants in Australia have had a very interesting history. And as everyone knows, there's a breast cancer. There's not a breast cancer, sorry. There's a lymphoma associated with breast implants called breast implant associated anaplastic large cell lymphoma. We just call it ALCL for short. There is this large cell lymphoma, which is a T cell lymphoma that has a higher association if you have breast implants. Now, the story doesn't just end there. If you were out in the community, the chances of getting this lymphoma is roughly 1 in 100,000. So it's very, 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 very rare. We know that if you have a breast implant, you increase this risk. Studies have shown that the type of implant does make a difference. The implants can be textured, so you've seen them, that they're textured, and implants can be round, smooth. Sorry, I should say smooth or textured. The textured implants, I explain it to my patients, it's like going to Bunnings and buying sandpaper, where you can have fine sandpaper and coarse sandpaper. What we've found is that the implants that were made of the coarse sandpaper outer lining were the ones that carried the higher risk compared to the ones that had the fine sandpaper lining. Implants that had no sandpaper lining haven't changed. So it becomes a question of how much risk are you willing to accept when it comes to putting an implant in. If you want zero risk and don't want to have any risk of having this lymphoma, then you would have a smooth implant. You can only have round implants if you have smooth implants. Smooth implants do not come in a teardrop shape. If you wish to have a teardrop shape, then by definition, you are going to need to have a textured implant, a fine sandpaper implant. The coarse sandpaper implants have been taken off the market in Australia, so you don't have to worry about them anymore. Really, the fine sandpaper implants, some of the companies that use them is Mentor, is Motiva, which uses a slightly different technology, but they also are very, very, very fine textured, but they don't have it in a teardrop. And then there's some of the other brands like Polytech that have started to come into developing similar implants. Of the brands that are out there, my personal preference is the Mentor brand, with Motiva being a good second choice. depending on the patient. I find the risk ratio went from 1 in 100,000 to 1 in 86,000 and may have settled at about 1 in 36, 1 in 37,000 for mentor implants, whereas the risk ratio went from 1 in 100,000 and dropped to 1 in 1,000 for all the other macro textured implants. So I think if you've got a competent plastic surgeon who's board certified as a plastic surgeon, and they're using either Motiva or Mentor in particular implants, particularly Mentor implants if you're considering teardrop shape, then I think they're great brands. Now, that may change. In 2 years, I might be saying something different if new research comes through.
Yeah.
But based on my patient preferences and what I've been using, they're the two that I'd lean towards.
Yep. Awesome. And last question, can we see the dog?
Nah. He's downstairs. I think he's in a bit of trouble, but see if you can see that. Oh, is that coming up? No. That's not coming up, is it?
You know what? Send me
There.
a picture and I'll put it on the post. Oh my God, I can see it. Send me a picture and I can put it up here on the post because everybody loves a puppy.
I will. I'll bring it. I think. Let me just find out. I'll see what it's doing. Give me 2 seconds.
All right. Honestly, this is the cutest dog. I'm pretty sure he's a little cavoodle. And I was talking to Rohit on the phone and I could hear something in the background and the dog was going crazy. And then I found out his name was Rocket. And I said, just because you've called him Rocket, he is going to be like a rocket.
He's the total opposite right now, but he does live, so he's sleeping. So I'm not going to pick him up. I'll have to wait.
It's like a baby. Don't touch the sleeping baby.
Leave him alone.
Look, I've got to say thank you so much. Now,
pleasure.
Somehow, I for some reason, I can't click into the rest of the comments. It's not letting me through. So there's a few other comments there that I can't actually read. So if there's anything, do you mind if I send it to you later?
Not at all. Send it through to me via Facebook or whatever, and I'll get it. I'll reply to it by either today or tomorrow, hopefully.
Now, before you go, Kyla's just said, I can answer that question slightly. I didn't ask about size. I just let Rohit choose.
Now, I do want to talk about my patients, but Kyla was, so that's very kind of her. Awesome. We've got to be proportionate to the patient. It's very important that, my group of patients, that everybody has different type of patients that come to them. My patients want a nice, natural looking breast that is full. But you notice the whole figure. You don't just notice the breasts as they walk into the room, and that, to me, that's a nice natural result. Exactly.
Sorry. Thank you so much. Pleasure. You're allowed to go and have dinner now.
Thank you. Appreciate that.
Thank you so much for your time. I really appreciate it. I know how busy you are, and to take that hour out is just amazing. Thank you so much.
No problems. See you, everyone.
Awesome.
Bye-bye.
See ya.